I'll straight away go to the crux of my presentation. It's a case in box I have recorded because there's no other way to explain to you how to do saline OCT. This is just a normal way of introducing the OCT catheter.
We just introduce a catheter just beyond the area of interest. Just make sure that your thing is coaxial. Confirm it by a small whiff of contrast. Small whiff of contrast, please. Okay, you're coaxial. That's good. So after that, you change from this to a 20 cc syringe. I use 20 cc for this. Okay. There will be some contrast which is already there in the guide, which will be injected. So that will be there. Let that be there. That helps you to initiate the run. This is how you hold the 20 cc syringe. Then you talk to your gentleman there and tell them ready.
Syringe.
Saline.
Inject. Stop.
Okay. I think we got a reasonably good image.
So this is the quality of the image that we get with just about 1.5 ml of contrast, which is there in the guiding catheter. So that's the ideal way to do things. Just make sure that you're coaxial.
We had engaged, there was a little bit of contrast in the system, so that we use that. This time I'm doing with absolutely only saline. Ready?
Finish, sir. Inject.
Good pictures.
So even that 1.5 ml of contrast need not be there, and without that 1.5 ml of contrast also, I got the images as good as it can be. Now, second option is once you're finished with the case. So once you're finished with the case, in this case I've done a left main. So you can see that the catheter is very close to the stent in the, sorry, I'll just pause this. So when the catheter is very close to the left main and you have a contrast, you have to take a shoot. That is the time when you have to be careful. You should not deep engage the catheter at this stage. So in which case you may not get a beautiful OCT run with the saline. In which case what you should do is simply have a combination, say 30-70, 30% of contrast with 70% of saline. Even then your total output of contrast becomes extremely minimal. And so that way, two things can be achieved. One, as the previous speaker said, a last shot which will tell you whether you have placed your catheter well and you're not damaged any of the distal vessels, any perforation, slow flow, all those things can be done. But however, the contrast use will be about, I use a 20 cc syringe, in which about 5 cc would be contrast, 15 cc would be saline, and in that I will only inject about 12 cc. So in short, I'm injecting about 2 cc of contrast for my whole final shoot. So this is the way you do the practical way of doing it. This is from the RCA side. RCA invariably I do only with saline. You may not get perfect images all the time, but the area of interest, if it can be seen, then that should be adequate enough for you to do this thing.
OCT, please. So I just try and demonstrate the concept of a saline OCT for you.
This is the second.
So what I'm doing is
recording.
Nothing unusual about it. We just introducing the OCT catheter. Joel is holding the other side. I go in. The crux of the situation or the solution or the success story depends on how coaxial you are to the left main ostium. It goes in smoothly despite the dissections. Okay. I've deep engaged so that thing's all right. Give NTG, please. Good. Now I'm taking. So what we have done is we have already not required. We have some sort of a contrast inside the 1.5 ml of contrast would be there inside the guide, which also I'm using for my directions. Go ahead, please. Good shot, no? So we don't require another thing.
So all the
parameters.
parameters.
There's too much of dissections there.
Yeah.
Predominantly, it was done with the saline with a little bit of contrast that was there in the. Please get the wires out properly.
Just shows the analysis. Analysis tells you that you are comfortable. So for the saline contrast, all that you require is that you have to be coaxial. I do predominantly hand injections. Now there is an option of doing it with the pressure injector. The issue there is various vessels, depending on the dimensions and size, you have to have a different PSI setting from 300 to 400 PSI. If you go 400 PSI in a small vessel, you're bound to dissect it. If you go at 350 PSI in a large vessel, you're not going to get an image, and you require about 20 to 25 ml of saline per injection, depending on the size of the vessel. I'm working on it to get a statistically reliable source, reliable data, so that I can tell you next time that, okay, if you're using a power injector, this should be your way of doing it. So this is another example of, just one more point I would like to stress. This is another injection of right restenosed coronary artery disease. So you can see the stents there. Distal dilatation is done just to get the stent OCT catheter across. Here we do the OCT in two different stages. The distal 75 millimeters, then the proximal 75 millimeters, because one OCT can't get you the whole thing. This is done with pure saline only. You can see that the catheter is being drawn back. After the saline first half is done, then you do the second half. Again, you get, okay, once that is done, you have to have certain landmarks. Then in about 80% of the cases, you can get an angio co-registration. So this is how the angio co-registration gets done. So you click on angio co-registration, co-register, just put the markers, distal, multiple number of markers. And if you're not getting it first time, the co-registration, you may attempt with a 30 frames per second angio run. You may get a better options of getting a angio co-registration. In this case, probably because of the extensive stented segments that were in between, we could easily co-register, and this is also possible. So you can do it, you can co-register, you can also get excellent images by doing this method. So I've been, for all the RCAs in my practice, I've been doing only with angio with saline. However, the last shot is always invariably done with 1:1 or 30-70 or 60-40. Usually 30-70 is adequate, 30% of contrast and 70% of saline. That helps you to do two things. One, if the vessel is too large and cannot be imaged with the saline, then you get a better image with this. Plus, you can look for perforations and be happy with the last shot. Again, you use about 3 to 4 ml of contrast only for this combination shots. This is the final shot that I usually do, so that I can get the co-registration, I can get the distal vessels, I can rule out any perforation and or slow flow. This is an example of a MERIS. MERIS is a biovascular scaffold in the RCA. You can see that the pullback is excellent. You can see that the struts of the stent can be seen very well, and the RCA is a huge vessel with an area of 11.13 millimeters squared. As you can see, you get excellent results. And this is the post pullback cross section. Just you can see the speckles. If you see so much of speckles inside, you have not used contrast. You use saline. That's the only difference. You can do all your reconstructions. You can do a fly through. Whatever is possible can be done. So finally, the last two slides is the first article which we published in 2018, when we had study. We did a saline coherence tomography, guided percutaneous inversion, a pilot study, and then we have a lot of questions came on what is the vessel size, how much does it change when you do saline versus contrast. So we did the second study on 113 cases of saline and OCT done in the same sitting, in the same patient, and came to a conclusion that the changes to the vessel size are not statistically significant.